we had Australian Healthcare Services Group, AHSG, come and take a look at a snapshot of the current state of our outpatient services operating out of Gosford and Wyong Hospital. There had been a previous review which we didn't actually, I wasn't aware of, and discovered somewhere into this that had been undertaken in 2018, where there's quite a lot of guidance about a service model, but I'm not sure that a lot of action had been taken, and was partially overtaken, I think, by COVID distractions, probably somewhere through the middle of that. The scope of the snapshot that we asked Australian AHSG to do was focused around the public medical outpatient services. So we excluded nursing and allied health, and we were particularly looking at the current service delivery and trying to see whether were we doing outpatients according to best practice? Were they efficient and effective in what they were doing? Are we maximising the revenue opportunities for the district? So, of course, we maximise, though, it gives us capacity to grow. And are the right services being held under outpatients to meet the needs of the local community? Next slide, please. So I forgot to put in here about process, but there was quite a process of interviewing people, understanding the data of the outpatients that occurred, talking to various people throughout the clinics. I think there were some connections with GPs. They also spoke to the ministry leads about outpatients and attended a look at both Campbelltown outpatients, which had done some innovative work and was recommended by the ministry as somewhere that had delivered a good outpatient services, and also up at Hunter New England. So in the course of all of that, they provided a number of findings, and they really came into sort of three areas about improving the way that we delivered things, the operations of things. It was clear there was quite a variation in the way governance was managed in the different departments, and there's a number of factors to do with that. And then looking at the alignment of services with community need, it wasn't always there. There was a clear and resounding voice that it's often difficult to access, it's not available for the right things, it's hard to refer patients from a GP perspective, and from a patient perspective, sometimes there were waits and delays. So there was quite a number of variations and inefficiencies about how referrals are managed, how bookings are managed, how wait lists are managed, and the visibility of those, how time slots are managed efficiently. So people just being given a time to turn up, and then they might be seen hours later because they weren't actually allocated a slot. They were just told to come to a session in a morning or an afternoon, and how communication occurred both to the clinics and out of the clinics. There was a limited focus on monitoring activity. There wasn't clear availability of data and activity, and the alignment between that and the revenue and costs. So the difference for the clinics and us, and whether it was an activity-based funding clinic or it was a GREENUP clinic using MBS, and what was the right thing for that to be doing, whether that maximised the revenue to the service. So overall, in terms of the outcomes, the report had 57 recommendations. Look, to be frank, the report wasn't fabulous and in a lot of ways, and there was a lot of richness of information, but there was a lot of duplication, and it sort of broke a lot of its recommendations down into saying the same thing about, 6 times about 6 different clinics, rather than consolidating those. So we ended up with 33 quite operational recommendations that were about how we run the clinic, those processes that I've alluded to. And then there were 24 recommendations that were much more strategic about the governance oversight for outpatients for the district, and an observation really that in those places like Campbelltown and Hunter New England, where there'd been some improvement in this area and good clinic operations, that there was a clear governance structure, whereas we don't have a governance structure really across outpatients. They're often led, they're managed by a part of the hospitals, the acute services. They filter through the specialist departments, and so each of the things operate in a slightly different way rather than as a cohesive model across the district. I'm sure that will have been the experience of many of you, that if you're referring different people for different things, that it might be a different process, and you get different information and that sort of thing. So a lot of those repetitive recommendations, similar issues across multiple clinics, as I've said. So what we did was have a look and review the report and recommendations to clarify how do we use it. There was a richness of information. There was a lot of information in there. There was some great stories and examples. How do we use that? So I did a bit of work that was about really trying to consolidate what it was telling us and to create a meaningful plan that would really help us going forward. And I developed that into a proposal, took it to the executive leadership team to check my thinking, if you like, and we confirmed this as the way forward. So we ended up with 3 strategic objectives that were really trying to focus on the big picture, how we manage, lead, develop our services, and how we make sure they're responsive to the community. So the 3 things I think we needed to do in that was, first of all, we needed to do a bit of a check with a snapshot check that the findings we had around some of the medical clinics were similar in allied health and nursing. That we need to create a multidisciplinary task force to oversee this piece of work, that there's clearly a piece of work that needs to occur, and that we need good governance across that, and that we should establish a lead role to help facilitate that process for 12 months with a very well-structured documentation. The operational focus really came down to grouping a lot of those recommendations and insights into areas around referral management, how we organise our capacity and maximise our capacity, how we monitor and manage activity and indications around that, and also that revenue and cost tracking. Had a couple in there. Next slide, thanks. So what have we done? Well, we've put an additional lead on, and I've appointed Addie Bruce, who some of you might have come across. We employed Addie she's a registered nurse. She came to us having worked in other places at an ICU nurse by background, and she's got a master's in public health and various other things. I think she's studying law at the moment. So she's a multi-talented, very smart woman, and who we actually used to help us establish the voluntary assisted dying service for the district, from which was a 0 to 100, if you like, over a space of months. So Addie, because the voluntary assisted dying has now gone to business as usual, Addie was available, and what a great opportunity for us. So Addie stepped in to be an initial lead for this, and we're currently grading the position description for this service with a number of key sort of focus areas that the job is really focused on. So the goal is to oversee all of the operational recommendations and sort of sort out what we're doing with those, engage with departments, specialties, clinic leads, etc., looking to maximise the impact of outpatients in helping us to deliver the objectives in our clinical services plan, looking at specific initiatives to support standardising how we manage things. You know, again, this in a way to make it easier for our referrers and our patients, so that regardless of what their health need is, it feels and looks the same and has some consistency and regularity about it. That we actively participate in the establishment of new models of care and expanding models of care. So obviously we've got a whole virtual care strategy in the district. Connecting that to how our outpatients evolve and develop is key, similar to things like rapid access clinics and those services. Standardising how we set up a new clinic. So we do it, you know, a checklist, fairly straightforward way. Sometimes people tell me they spend months trying to make these things happen, which obviously delays the opportunity we might have. To advocate and represent outpatients in other planning activities, and to develop an outpatient model of care which describes some governance and operational processes. I suppose I see there's sort of a couple of pieces of work in how we approach this. We have established or identified a task force. Our first meeting is scheduled to occur next week with some senior clinical leadership and management. Addie's kicking off a project plan that will go for some consultation initially to that task force, and also started working on a stakeholder engagement strategy, which is a great opportunity. I'm hoping to stay connected with this group as well, and also looking to connect and align to some other key pieces of work that have already been underway or kicked off. So the engage outpatients process and the implementation of e-referral systems for outpatients, and which obviously we've rolled out in women's, children and family and neurology services, and really successfully over the last period of time, and also with the Outpatients Alternative Task Force, which is that work just starting with after our discussions at the Clinical Council with Dr. Nigel Lyons. Last slide, thanks. Next slide.
That's the last one, Jude. It's on your pink slide. Is it slow to move?
Oh, I missed it. Sorry, my computer is not playing nice for me at all. Yes, so the pink slide. So pretty much over the next 12 months, there's a number of things that are about really getting our house in order around the outpatients and having that solid foundation to grow, while at the same time we want to connect with a lot of the other work and planning that's occurring and the opportunities that arise through that, driven out of the directions in the CSP for what new outpatient services are the right way for us to support our community. So that's certainly, I suppose, just to summarise, it was a bit of a messy report, but there was a lot of rich information. There's certainly things to guide us in the way that we operate going forward. I think probably there's more of a 2-year piece of work initially, as I say, first year to get our house in order, to connect with what we're doing, and the second to really lead, you know, that evolution of the range of services we need to be developing to deliver on our key directions. Manage capacity. So very happy to answer any questions or